Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by our senior colleague, Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of Nath Arua and the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 407 of our pharmacotherapy series, which majors in headache. The next clinical case reads: VIM is a 24-year-old female, reporting to her primary care provider with a 3-month history of throbbing headaches. Although VIM has reported experiencing tension headaches, on and off, in the past, the character of these recent headaches has been different, accompanied by early onset, severe nausea and vomiting, and preceded by flashes of light and a unilateral facial numbness. The numbness and visual flashes have typically resolved after 30 minutes, with headaches developing soon after. She has taken naproxen or ibuprofen for treating recent episodes, but neither has proven effective. The MIDAS score was 11. Medical history includes hypothyroidism, treated with levothyroxine 100 micrograms by mouth daily, and a past history of tension headache. Her medication profile also includes an oral contraceptive, norgestimate co-formulated with ethinyl estradiol, for the past 5 years. She describes herself as an occasional smoker, and denies a history of alcohol use or illicit substances. So my question to you reads: which information is consistent with the diagnosis of migraine with aura in VIM? Although both the throbbing character of the headache and associated gastrointestinal symptoms are consistent with migraine, it is the presence of both the visual, that is light flashes, and sensory, that is numbness, disturbances correlate with the diagnosis of migraine with aura. Relevant information for confirming this diagnosis would be a minimum of 2 episodes, the accompaniment of an aura symptom, the duration and unilateral nature of the aura, and the evolution of the headache following the aura. Propagating glial and neuronal depolarization, characterized as cortical spreading depression, has been implicated in aura. It is suggested that the pathologic basis for aura involves gap junction modulation at the neuronal level of the trigeminal vascular circuitry. Aura has been associated with migraine in approximately 1/3 of patients, and visual phenomena are typically the most prevalent aura features. It is important to note that visual effects are substantially varied and can include flashing lights, waving lines, or areas of localized blindness, that is scotoma. Further, a visual snow effect has been described in the literature, bearing resemblance to television static. Although visual phenomena are most prevalent, sensory disturbances, e.g., numbness, pins, and needles sensation, may also comprise an aura. In the case of VIM, the aura includes both visual and sensory disturbance, and coupled with the report of additional symptoms, e.g., throbbing headache, nausea and vomiting, a diagnosis of migraine with aura is appropriate. The temporal relationship between the aura and evolution of the migraine is one of further consideration. Although VIM reports the evolution of the migraine following the aura, there is evidence to support classical migraine symptoms occurring during the aura phase. My next question to you reads: should the migraine that VIM is experiencing be treated according to a stratified care or step care model? In accordance with a step care model, a conventional analgesic medication would be considered as primary therapy. A stratified care approach is designed for treatment selection based on patient need. VIM has reported self-treatment with conventional agents, e.g., naproxen or ibuprofen, without adequate relief. Further considering that VIM's MIDAS score corresponds to moderate disability and the reported variance of MIDAS score with age, a stratified care model would be preferable. VIM has been counseled previously regarding the cardiovascular risks associated with oral contraceptives and questions whether she is at greater risk considering her migraine diagnosis. My next question to you reads: is an oral contraceptive appropriate for VIM? No consistent increased risk for stroke has been found among men, women older than 45 years old, and women who have migraine without aura. Among patients with a diagnosis of migraine with aura, a twofold increase in ischemic stroke risk has been reported. An additional finding in this meta-analysis supported an increased risk among migraine patients using oral contraceptives. The World Health Organization considers migraine with aura in women of any age an absolute contraindication to the use of combined oral contraceptives. The American College of Obstetricians and Gynecologists guidelines permit the use of combined oral contraceptives in women who suffer from migraine with aura as long as they have no focal neurologic signs, do not smoke, and are younger than 35 years of age. VIM describes herself as an occasional smoker, so relevant management strategies include discussing other contraceptive options and/or a smoking cessation plan. The next question reads: what is the most appropriate recommendation for acute management of VIM's migraine? Given the severity of symptoms and past treatment experience with conventional analgesics, the selection of a migraine-targeted treatment, e.g., ergot alkaloid, Triptan, would be preferable. Of similar importance is the presence of severe, early-onset nausea. Therefore, a non-oral administration is recommended. Sumatriptan and Zometriptan are available as non-oral formulations, and either could be considered appropriate for VIM. A limiting factor in the selection of ergot alkaloids as a primary treatment would be the potential for drug-associated nausea. VIM has now returned to her primary care physician reporting success in managing her migraines with Triptan. The frequency of migraine episodes remains an issue, reporting 4 to 5 episodes monthly which have caused her to miss work. Her primary care physician is considering prophylactic treatment, but would prefer not to prescribe propranolol. Which medication may be prescribed to prevent migraines in VIM? Let's first look at amitriptyline. Amitriptyline is an appropriate first-line therapy option for migraine prophylaxis, with such effects being independent of antidepressant activity. Demonstrated blockade of sodium currents in trigeminal neurons and blockade of 5-HT reuptake is the basis for the potential efficacy in managing migraine, although a complete mechanism has not been fully elucidated. Amitriptyline treatment has been associated with significant improvement in MIDAS scores. Such an effect has been demonstrated following a 45-day treatment cycle. Particularly applicable to the case of VIM, there is demonstrated benefit for amitriptyline in the treatment of tension-type headache, as well making it a viable option for patients with both headache forms. Amitriptyline has been compared with propranolol, valproate, and topiramate in various studies. A randomized trial comparing extended-release valproate with amitriptyline, 150 subjects in each treatment group, yielded similar efficacy, measured by headache frequency at 6 months, while being inferior to valproate at 3 months. 2 separate studies have provided comparison between amitriptyline and topiramate. With a primary efficacy measure of monthly migraine episode rate, 100 mg doses of each proved comparable and similarly well tolerated. A smaller study reported similar results. However, the combination treatment of amitriptyline and topiramate was assessed as a separate, third treatment arm. Patient satisfaction among subjects taking the combination was noted to be higher relative to either monotherapy group. Let's now discuss dosing. The initial dose of amitriptyline is 10 to 25 mg by mouth at bedtime. This nightly dose can be increased at weekly intervals by 10 to 25 mg until the maximal dose of 150 mg per day is reached. While generally tolerated, common adverse effects attributed to amitriptyline treatment have included drowsiness, anticholinergic effects, and weight increase. And now we will look at topiramate. Topiramate is considered a first-line option for migraine prophylaxis. In addition to aforementioned comparisons with amitriptyline, prospective studies have reported similar efficacy between topiramate and sodium valproate. 3 large randomized, placebo-controlled trials have documented the efficacy of this agent for reducing the number of monthly attacks. With initial dosing of 25 mg daily, target doses of 100 mg daily and 200 mg daily have been assessed. Evidence supports dose titration to 100 mg for optimal outcomes. Further titration to 200 mg has not demonstrated significantly better outcomes relative to 100 mg. Paresthesia, fatigue, weight loss, memory, and concentration deficits have been associated with topiramate therapy. Next we will talk about valproate. Valproate and valproate sodium are approved for migraine prophylaxis and are viable treatment options for prevention. An extended-release valproate sodium formulation has demonstrated efficacy relative to placebo. Versus active comparators, equivalence in efficacy has been reported for propranolol and topiramate. The selection of valproate as a therapy for women of childbearing age must be evaluated cautiously, in light of potential detrimental effects in cognitive development. Let's now look at its dosing. Delayed or extended release formulations of divalproex sodium, e.g., Depakote or Depakote ER, may be prescribed for prophylaxis, with the advantage of the latter formulation being once-daily administration. Initial dosing for the delayed-release formulation is 250 mg by mouth twice daily, whereas the extended-release formulation is 500 mg by mouth once daily. Adverse effects associated with valproate treatment include alopecia, nausea, drowsiness, and weight gain. Potential for hepatotoxicity and pancreatitis limits utility. And now let's look at gabapentin. Gabapentin possesses a complex mechanism of modulating calcium channels, increasing GABA concentration centrally, and binding to gabapentin binding protein. A randomized trial versus placebo demonstrated superiority of gabapentin 2,400 mg per day in reducing migraine rate over 4 weeks. Secondary outcomes related to severity, functional capacity, duration, and aura severity did not yield significant differences between treatment groups. Let's now look at candesartan. Candesartan, an angiotensin II type 1, abbreviated as AT1, receptor antagonist, has demonstrated efficacy, based on an intention-to-treat analysis of 57 patients, in migraine prophylaxis in a randomized, placebo-controlled, crossover design. Outcomes of migraine frequency, that is number of days, and duration, that is number of hours, were favorable with candesartan. Although dizziness was the most frequently reported adverse event associated with treatment, neither this effect nor any other adverse outcome differed significantly from placebo. Let's now talk about tonobursat. As both cortical spreading depression and gap junctional modulation have been linked with migraine aura, the inhibition of CSD constitutes a potential approach to treatment. Tonobursat functions as a gap junction blocker. Comparisons with placebo have been mixed, with efficacy exclusive to migraine with aura. Tonobursat is currently an investigational treatment. Next we will discuss nonsteroidal anti-inflammatory drugs. Effectiveness as preventive therapy is considered to be modest compared with the first-line agents. Nonsteroidal anti-inflammatory drugs may be effective as short-term therapy for menstruation-associated migraine. In selecting an alternative prophylactic medication for VIM, evidence supports use of either a selective beta antagonist, e.g., metoprolol, amitriptyline, or topiramate. In all such instances, VIM should be counseled with regard to dose titrations, adverse effects, and allowing for a sufficient trial duration to adequately determine efficacy. So there you have it. Our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. On behalf of our senior colleague, Dr. Nath Arua, I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 408.